Good morning once again. My name is Getrud Mollel, and today I'm very happy to moderate this important webinar and hopefully a beginning of something bigger, a journey that we'll all go through on introduction on evidence-informed decision-making. And we're very delighted to be joined by Barbara Miheso and Wambui Njonge, colleagues from KEMRI, Kenya, and also from Cochrane, Kenya. And so before I welcome the head of department, Dr. Grace, to say a few words, I just want, together with acknowledging you, setting out your time, I just wanted to say a few words that as researchers at IHI and also in collaboration with many colleagues out there, we work so hard to make sure that we produce robust evidence that we believe right from the outset of when you're writing that grant or when you're looking or joining that consortium, we hope that the research evidence that we produce will be used in decision-making and to influence policy. And that is not an uncommon phrase in our proposals, where we say finding out about 1, 2, 3 will inform policy in multitude of ways. But then we also know and acknowledge that usually decision-making is not done by researchers. We influence, but there are policymakers positioned in place that they make the decision. And the challenge that we are taking on as we embark on this journey is that how do we position our evidence for use? And this includes evidence from the research that we do, but also evidence that is out there. And not forgetting that we speak of robust and quality evidence, of course. And on evidence-informed decision-making, we look forward into being able to influence that scientific-based evidence together with contextual realities, values, and preferences are used to guide health policy and practice. And this including both evidence from research and utilizing evidence from routine health information, so that we really are able to contribute to the well-being of the population and improvement of population health, especially in the current moments where we're facing complex health challenges, in a mix of epidemics and communicable, non-communicable diseases, outbreaks, etc. But also we're positioned to be working in an era where there is evolving technology, which was not there when maybe many of us were born. It was not as advanced as now. But then also we are in a time where there is a lot of shifting in the funding ecosystem, and this shifting is very unpredictable. So it's really high time to know that the resource that we put in finding evidence and the evidence that is out there is used appropriately, and it's just so much right when the robust evidence is used to get decision-making with a goal of course, improving population health and our health system. So at this point, I hope Dr. Grace Dr. Grace is on the call. I want to welcome her to give us a few words. And then after that, I'll come back to introduce our first speaker of the day and welcome her to take us through the presentation. We're hoping to use 1 hour or less, and by 10, we'll be able to let everyone continue with their daily programs. Thank you very much, Dr. Grace Karibu.
Thank you very much, Dr. Getrud. You have said it all. Good morning, everyone. My name is Grace Mhalu. I'm the head of Health System Department Impact Evaluation, for those who have not met yet. And it is my great pleasure to welcome you all to this webinar today. We are very excited to hold our first webinar on this important topic as the department. But we're also excited for our two experts from the field, Barbara, but also Wambui from Cochrane, Kenya. This is a great opportunity, and we are really, we appreciate you for welcoming this idea to you and for also being able to, our request of holding a webinar with you was granted. So today's webinar aims to explore how we can strengthen the bridge between research and policy, as Dr. Getrud has said, but also how we can produce evidence that can be used with decision makers and how we can empower the decision makers to ask the right questions on the evidence we produce, but also for us as scientists and researchers, how we can answer these questions with actionable answers and evidence, as you have said, Dr. Getrud. So we are very excited, and let us all engage, ask questions, learn together. And as you've said, this is only the beginning of a very great collaboration, but also a very great initiative that we are undertaking, not only as a department, but also as IHI in general on evidence decision-making initiatives. And with this, let me not use a lot of time. Back to you, Dr. Getrud.
Asante sana, Dr. Grace. Thank you very much. And so I am very happy today and very honored to introduce Barbara Miheso, a colleague and a friend that I met for the first time last year when we went for the summit in Czech Republic. And Barbara is a research scientist and a clinical trialist at the Kenya Medical Research Institute. And she's also recognized as an emerging woman in science champion in East Africa. She's passionate about evidence synthesis and knowledge translation, and she has spent the past 5 years championing the dissemination of contextualized public health research evidence to decision makers. Barbara also serves as a co-director of Cochrane Kenya, where she provides strategic leadership in promoting evidence-informed healthcare. Her work informs capacity building in systematic reviews and knowledge translation, mentoring researchers, healthcare workers, policymakers, and fostering partnership to champion the use of research evidence in policy and practice in Kenya and also across the region. Her commitment is reflected in her daily work that, and if we go read about her, we'll find she has contributed to a lot of work out there. And as I said, she's again recognized as a champion among emerging women in science in East Africa. It's now my pleasure to welcome you, Barbara. Karibu sana to take us through the presentation. And once you share again, please just put in presentation mode. Thank you, Karibu. Barbara, over to you.
Thank you very much, Gertrude. It's a pleasure, such a pleasure to be here and to have this opportunity. Greetings from Nairobi, warm greetings from cold Nairobi. We are freezing here, but we're sending warm greetings to you. Shikamo, that's where my Kiswahili ends, so that we don't start a Twitter war between Kenya and Tanzania, but it is a pleasure. I'll try to keep it short, simple, and interesting. So, definition of evidence decision-making. So in our field and in the field of medicine, we are faced with a lot of uncertainty. Like we are always faced with conditions and situations where we need to decide or make a choice between one thing or the other. So there are two treatments for TB. Can you go with treatment A or treatment B? Even in your day-to-day life, you want to buy a car. Which car should you go with? Should you go with a Mercedes? Should you go with an Outback, because that will be able to fit your family? We are always faced with different decisions to make in our day-to-day activities. So our aim is normally to make decisions that have the best outcome. And evidence-based practice is really about making more informed decisions. It is important to think about what are the differences between what we seem to normally do and what the evidence-based practice approach is. So initially, the main emphasis has been on using published research as a basis of making decisions about maybe treatment of patients. But a group of researchers led by Sackett et al., they did come together and from McMaster University and redefined the whole idea of evidence-informed decision-making. And they say that it is a conscientious, explicit, and judicious use of evidence in making decisions. What do we mean by these terms heavy terms you're using here? So conscientious means that you make a lot of effort around gathering the evidence. So you don't just go to one place. Have I looked at gray literature? Have I talked to experts in the field? How many databases have I used? Have I looked at different communities of practice to see what do they have in terms of a particular question of interest to you? Explicit means that you have to share. Whatever you do, you put it out there so that if I go and want to repeat the same work, I expect to get the same results. So you share and be open with your methodology and with your results. You say what evidence and information and data you're using. Judicious, here we mean that we are judging the quality of that information. So it's almost like a whole general approach. So for example, if you take just the judicious bit, an important part of evidence-based practice is not that all evidence you see is what you use. You actually go for the best available evidence. And so as researchers, we're tasked to produce the best available evidence. So this evidence ecosystem, or rather evidence-informed decision-making, is an interplay between three key pillars. So the first one is relevant scientific evidence. And here we're talking about the best available evidence, as I've just mentioned. And this model prioritizes the use of the most current and robust research evidence from clinical studies, systematic reviews, and meta-analysis, etc. And evidence should be critically appraised for validity, relevance, and applicability. So not all evidence, it can be best, but unfortunately, it does not apply to your context. The second pillar is clinical expertise, and the clinical judgment, experience, and skills play a critical role in interpreting that evidence that is available and applying it to the different individual care. So the expertise bridges the gap between general evidence and specific clinical scenarios. The third is patient values and preferences. And the patient-centered care requires considering patient unique preferences, concerns, and expectations. So these three key pillars cannot exist alone. There's a lot of interplay between those three items that we have discussed. So this is just a diagram to show flow of evidence from research to policy and to large scale change. And this flow is a well-articulated depiction of what was put in the Handbook for Global Health Policy. And this Global Health Policy book was published, I think, in 2014 by Brown and DMA and Wamala. And it shows there's a particular chapter on narrowing the gap between knowledge and action. So this shows that the process starts with evidence generation. So as researchers, we are here at the beginning where we are generating primary evidence to answer questions that are relevant to LMICs or relevant to our context. After that, then it will go into, the primary research goes into systematic review of evidence and still relevant to the LMICs. This evidence then reaches the policymakers, and then we hope that the policymakers will value this evidence, because remember, you might have the best evidence, but do not speak to what the policymaker wants. Is not in the, it does not answer to the current political climate. So they might choose not to use it at that particular time, yet it answers the critical questions in your setting. So once it reaches a policymaker, we pray that the policymaker values that evidence and uses it for decision making, and then the policymaker will facilitate large change scale. So once we are at the policy uptake phase, this is where evidence starts to shape different discussion and influence different priorities and actually guide decisions at that stage. But this stage is not automatic, as I've said. As the author of this book and chapter emphasizes, that policy is shaped not only by evidence, but also by political interests, the resource constraints, and institutional context. This means that timing is very important. How is the relationship between the researcher and the policymaker? Because policymakers rely on what the kind of relations that have already formed, and trust the matter that is just as evidence as itself. So when you trust a certain person, like for example, I know in Tanzania, the Ministry of Health know that Ifakara answer to different health priorities in Tanzania. So when they have any question that they need to be addressed in a certain section for health, then they already have a relationship with the Ifakara, and they know that they trust that whatever evidence you produce is what that they'll use for making their decision. And once the policy is in place, we move forward in the implementation and scale up. And here the flow of evidence must continue. So this time to inform how interventions will be adapted and how they'll be monitored and how they'll evolve in the real world setting. So the evidence ecosystem has 3 key pillars: evidence generation, where now the evidence is produced; synthesis, where this evidence is put together and put in a format that can be used to inform certain decisions or change in practice. Then we have the evidence translation. But these do not occur in isolation. We have a lot of other players in this network. So we have the politics. Well, how is the political environment? How is the culture? What are the social interactions? What are those social predictors that are in play? Economy, you might have a very good drug for treatment of, for example, or managing pain crisis in sickle cell, but it's very expensive. So it cannot be taken up by the policymaker and implemented in that setting. And then you have the regulatory, where there are the rules and policies in that place, and that actually play to affect how the evidence generation, evidence synthesis, and translation, how that interplay works. But at the end of it all, our main goal is to improve health and health equity. So this is just a summary of the challenges of evidence use by the different players. So we have the policymakers and the clinician in one quadrant. We have patients. We have those who are supposed to be implementing the evidence, those evaluating the impact of the evidence that is being produced. And of course, in the beginning, the evidence being produced by the scientists and all those who are in the beginning of that whole cycle. And I won't go into details of this because I know that we have come into some of these challenges, especially from the policymakers, complaining that the evidence you are generating is not speaking to the priorities, or it is not, it is exciting, yes, but they do not see what value you are adding. The patients are looking at evidence that is being produced is not well disseminated. They can't get summaries that they can easily interpret and use in their context. And so they can't use it to make any decisions. And then we have the siloed communities, especially us in scientists. I don't know about you in Ifakara. So we find that we are very siloed in how we are doing the research. And then there's a lot of duplications in some areas. You find that there's a lot of disconnect just because of those silos that have been created. So I hope you can see my next slide on.
Yes, so, slides. Yes, proceed.
Thank you very much. So understanding the political economy in evidence-informed practice is very key. So we have to, one thing we have to be clear about is that the primary objective of the politician here is to maintain power. So every public action they take serves that purpose and that purpose solely. They want to maintain whatever power they are holding. And so we have to, they always weigh or evaluate the risk versus the interest when you present whatever evidence you have to them. As scientists, we need to rethink how we communicate knowledge. We have always done policy briefs, we do dissemination workshops, but I read an article and this guy was suggesting that it's time we be innovative. Apparently, policymakers now are more on and are very active on TikTok. Can we consider using that as a knowledge sharing platform? That's just a suggestion. We need to stay humble about the role of evidence, because evidence on its own is not enough. And evidence is only one ingredient in the policy making process. And often it's not the most decisive, unfortunately. So as researchers, what can we do? First and foremost is what is very key and important is priority setting. We risk being irrelevant if we are not speaking to the needs of our stakeholders. So how do we respond to what are the gaps, what are the needs of our healthcare workers, what are the needs of our patients? We have found that normally we are responsive to calls, funding calls, or we sit and come up with ideas and think that there's a gap in this area and this should be addressed. And so more often than not, we find that we're not speaking to the needs of our stakeholders. So there are a number of papers that have been published, and there are checklists and guides that we can use for priority settings, but we need to ensure that we are responding to the needs of our different stakeholders. During COVID, there was this group that was formed by WHO, and the team, this page was called COVID End. And for them, they are just trying to, to reduce duplication, because when we have a lot of duplication, there's time and resources that are wasted. And so they came with us up with a framework that we can use to help to make certain decisions. So if you have a certain question, the first thing you do is to go and assess what evidence is available in whatever topic of interest that you have. So look at the evidence. Is there a review that has been done in that area? If there is a review already, because you remember systematic review in the hierarchy of evidence is on the top of the pyramid, and I think there's a section where we discuss the different, the hierarchy of evidence and the pyramid of hierarchy of evidence. So you start with the systematic reviews. Is there one? Yes. If there is one, is it current? Is it credible? Was the review comprehensive? If you have assessed it for all these elements and found that it is a tick on all of those, then you use the review to do whatever work or decisions you need to make. If you see that, yes, there is a review, but it's not current, and then you'll decide whether you want to do update a review, or you can consider doing a new review if it has been more than 5 years since the last review has been done. If there's no existing review at all, then now here you identify a research question and do a primary research to answer whatever gap it is that you have found. So this is just a guide to help you avoid duplication, to help you better make decisions in terms of responding to different calls or gaps or research questions that you may have, so that you don't waste time and resources doing something that has already been done, or doing something that will not be responsive to the different needs. There is group called Equator, and this page is Equator Network. You can just search for them. Equator stands for Enhancing the Quality and Transparency of Health Research. As a researcher, you need to ensure that after determining the priority, doing a priority setting, then you look at the quality and the robustness of the research work that you're doing. You have to ensure that the research you're doing is of good quality, and the methodology that you have used and rigor is right, so that it can be used into or included into reviews for decision making. Equator Network have very many tools to help you evaluate different research that you're doing. So if you're doing, you have done an RCT and you want to report it, this you'll go to Equator, look for RCTs, and then it gives you a guide on the different parameters that you need to include into your paper, so that your manuscript is holistic and is of quality, and that you have answered the relevant and very key items as you're doing your manuscript review paper or publishing whatever report it is, whether it's a systematic review, whether it's a case report, whether it's a clinical practice guidelines. If you go to that portal right now, there are around 676 reporting guidelines available for use. So it speaks to different kinds of research processes and different kinds of structures. So whatever you want, you can find in that portal and can help you enrich your report so that it can be used for decision making. So as researchers, what is key is that I think this is the wrong version, but it's fine. So what is key is that for us as researchers is that we need to conduct research that are answer relevant questions. We need also to take time and do stock taking of existing research. Because we want to see what we are using, is it to inform new research, so that you know whether you need to do a real research or a review can be done instead of doing a primary research to answer a certain question. You need to have the right teams, because having the right team means that whatever work will be produced is quality. You have to ensure that you do the research well, and after you've done the research, remember there are tools and guidelines that you can use to help you in your reporting and to assess your work. Why is it important? Because poor reporting can be just as damaging as poor research. You have a bad report, no difference from having a terrible research. So when key details are missing, like how participants are selected, how interventions were delivered, or how outcomes were measured, it becomes hard to assess the quality of that study or replicate it or use those findings in practice or policy. So Equator Network invested in putting a number of guidelines, very many of them. As of today, there are 676 reporting guidelines to cater to all the many research, the different research methods that we have. You see, we have RCTs, observational studies, systematic reviews. So when you're writing your paper, this is a good source to consult, so that you pick whatever guideline is of relevant to your research. If you're doing qualitative, pick a qualitative guideline and just assess the different components to ensure that the key issues have been addressed. So beyond the guidelines themselves, Equator, they do offer a lot of training, and they have toolkits and other resources to support researchers, editors, or peer reviewers, or even journal publishers. So take time to go look at that website or page and just interact with some of those guidelines that they have published based on whatever studies it is that you're doing. So as you prepare your next manuscript or review, or you're reviewing one of that publication, I encourage you to consult this website. It's not just checkbox exercise, but it's a vital step towards making our research more useful, reproducible, and impactful. So what can we do as researchers? I hope it has moved to the next slide.
Yes, it has. Yes.
Okay.
Yes.
So as researchers, it is up to us to conduct research that is relevant to our priority settings. So have research responding to the needs of our stakeholders. We need to do stock taking of existing research and use it to inform new research. It is paramount that we form the right teams, and we are encouraged, or rather we are mandated to do research well. And so as you're doing your paper and your final manuscript, like we said, Equator will help you to ensure that you have a robust paper, so that communication to the different audiences is done well. And then invest in the next generation. Are we mentoring young scientists? Are we working with young people in our teams? One thing about evidence-informed decision-making is that we need to understand the political economy of the evidence-informed policy. So let's be clear. So the primary objective of politicians is maintaining power. Most of them, they just want to maintain their power. And every public action they take serves that purpose. And it's a risk versus interest that is calculated. We need to rethink how we communicate knowledge. So for the longest, we always do with policy brief, we'll hold dissemination workshops. we'll hold dissemination workshop, but we are encouraged that we need to be more innovative. One thing you have noticed that it's interesting that policymakers seem to be more active on TikTok than on any other knowledge sharing platform. So can we use this as a knowledge sharing platform, as in TikTok, to policymakers? I mean, that's a food for thought. We need to stay humble in terms of the role of evidence, because evidence only is one ingredient to the policy-making process, and often, unfortunately, is not the most decisive. So the research we are doing, research is just an output, yeah? It's not an outcome. The image I'm sharing here is a challenge that many of us face in the research community, and we are familiar with. So what we often refer to is referred to as the no-do gap, or the evidence to impact gap. On the left side, we see research outputs, and this represents the studies that we are conducting, the data we generate, the articles that we publish, and it's intellectual output of our scientific effort, and normally full of insights, discoveries, and innovation. On the right here, we have outcomes. This is real-world improvement of health systems, patient care, or population well-being. This is what ultimately matters, that we save lives, that systems are strengthened, and health equity is advanced. But between these two, there's a visible gap that often persists. And we want to, it is our work, and we are here to support as KM Knowledge Management, KEMRI and Cochrane Kenya, to be able to support and work with Ifakara and even have collaborations to see how best to bridge this gap between evidence and practice. And this gap exists for many reasons. And sometimes research isn't translated into formats decision makers can use. Sometimes it's not timely, or it does not reflect our realities of the context where policy is made or healthcare is delivered. So, and at times decision makers might not even be aware of the relevance of that evidence or whether it exists. Yesterday, I was having a conversation with one of our colleagues who's in drug discovery. So she's a chemist who's looking for different products to see from plants to see whether they can be done value addition, so that for drug discovery purposes. But when we discussed with her about knowledge translation and the fact that, you know, we can always have sessions with policymakers, she was like, no, we are just in the lab still developing the products. I was like, but if we are to engage with our policymakers so that they know what is happening, they can understand drug discovery and why they need to invest in such kind of initiatives. So us doing research, us as researchers need to incorporate policymakers at every step of whatever research we are doing. And be it basically foundational research like drug discovery, like I've said, or even clinical trials, they need to be involved at every step so that they learn and appreciate some of the initiatives that are going on. So our challenge and our opportunity is to turn outputs into outcomes and ensure that our science leads to real world impact. Now, a practical approach to evidence-informed decision-making is one, you have to define your problem. Remember, garbage in, garbage out. If we don't, we're not very clear about what our problem is, it means that we'll get our question wrong. And when we are looking for the different research evidence to include, it will be wrong. So we start getting the process wrong from the very beginning. So the problem definition and formulation of the research question can take such a long time and a back and forth even between researchers and policymakers. But after you get that step right, the rest just falls into place. So we start by asking the right question. You set the foundation of what evidence it is that you're gathering. Then we go to acquiring. You search for relevant, high-quality evidence. You have to leverage on different databases like PubMed, Cochrane Library, which Wambui is going to talk about, or local research repositories. we have to appraise. You critically evaluate the quality and relevance of the different evidences that you have. Look for factors like what study designs did they use? Did they assess for the risk of bias? How did they calculate their sample sizes? And consistency of the results. There are tools that are available for this, and I'm sure with more interaction, we'll discuss more of those tools like the Critical Appraisal Skills Program, and so that you can have a feel about this and appreciate some of those tools that are available for appraisal. Remember what we said initially, not all evidence is created equal. So rigorous appraisal ensures that decision-making is based on trustworthy evidence. After you've acquired, what do? You apply the evidence. So integrate the appraised evidence within the local context, values, and expertise. We are required to engage with the different stakeholders, including the patients and communities, to ensure that the intervention or decision is practical and acceptable. Remember, we said like the drug for sickle cell, the GBT is a new drug. They're saying it reduces the pain crisis in sickle cell patients. It is needed. We have not had a new one in a long time, but it's very expensive. Can you integrate it into the normal care of sickle cell? No. Locally, the local context, there's no funding to support that. So we have to look at local context, value, and expertise. Then the evidence must be actionable and context specific for it to be impactful. After applying the evidence, we have to assess, and this includes monitoring and evaluating the outcomes of decisions or interventions. For example, you measure the reduction, measure the reduction of pneumonia rates after implementing a new vaccination program. So you've got a new vaccine for pneumonia. It is rolled out in the different communities. You have to measure, assess the rates, or rather evaluate this program so that you close the loop and support continuous improvement in decision making. So what is evidence synthesis? I'll quickly go through this because I've been talking a lot about evidence synthesis. It's just the process through which two or more research studies are assessed with the objective of summarizing the evidence relating to a particular question. Remember, you have to be very specific. Take time to get your question. Ensure that it has the components of a quality question. So what is the population? If it's an intervention, have we described what the intervention is? What is the comparator? And what outcomes of interest are we looking at? So what is the importance of synthesis? It helps to identify knowledge gaps, establish evidence base for best practice guidance, and it helps to inform policymakers. Just to appreciate the hierarchy of evidence, our primary research, we can see where it lies. We have our clinical case reports and case series, and the expert opinions, which are at the bottom of the pyramid, because there's no design really to guide this process. Then we have our case control cohorts and randomized control studies. These are primary studies, and randomized being on top of the case control cohort and cohort because of the methodology. Remember, you're randomizing, so you're reducing bias, and we know all the elements of randomized control studies and why it is considered to be superior to the others. After that, we have our meta-analysis our systematic review and meta-analysis. What results we get for that is what goes to inform the different guidelines and practice. So this is how our hierarchy of evidence looks like. And now we appreciate that what goes into systematic and the review and meta-analysis are actually those primary studies that are synthesized using different methodologies, depending on what kind of review you're doing. And maybe in another setting, we'll talk about the different types of reviews and what gaps or what evidence they address.
Yes, so just a second, Barbara. Thank you very much. It's really interesting. May I just ask everyone if you could allow us 15 more minutes? I check this time to promise on behalf of Barbara and Wambui that we check 15 more minutes and end at 15 past 10. But there is more good news because Barbara will be coming physically to IHI. So we'll have a lot in the near future. So if you could be able to just summarize what you have left, Barb, and then we'll have the rest in the next time we engage in sort of 3-4 minutes. And then I will ask Wambui not to use the slides, but to also tell us what she wanted to tell us in 4 to 5 minutes, so that then we are able to answer key question and to close not later than 20 past 10. Thank you, Barbara. I give you 3 minutes.
Thank you for that. And again, I truly apologize for the mishap we've had. I think what I can conclude with is that we have talked about the research question and how important it is. And it is important to appreciate that we have different questions depending on what your question will help inform what design you will include. For example, if you're doing a diagnosis or screening, for how accurate it is. Here, diagnosis or screening, it means that we're going to either use cohort or RCT to answer your question. If you want to understand why experiences of meaning, then the best evidence that you can use in terms of your systematic reviews to answer your questions is you include qualitative studies. One thing I'd like to say also is that, yes, so we have discussed about the hierarchy of evidence, but sometimes you can have primary studies that are enough to inform change of practice or change of policy. Based, like those large population studies that are done sometimes, like those malaria population studies that have very big sample sizes, can be used to inform policy. If you have something is very innovative, like recently we had research that was done on mosquitoes, and they found a new species of mosquito that now can dwell in the urban settings, and it bites during the day. So this one actually helped to inform policy and changes, because we knew that now there can be transmission. You see, now all the strategies had been geared towards a certain area where they saw that there was high prevalence of malaria. But now here we are, we are having a mosquito that now is in the urban setting and can bite during the day. So then those strategies should also be used in the same urban settings and not just in the rural settings. So you can have situations where you have one study that can help inform policy change or even practice. So in summary, I think I will end there, because I think I can just end with this slide of different sources of evidence. When you Google, we have different guideline portals that you can help to find different guidelines in different disease areas. Electronic databases, we have the Cochrane Library, PubMed, Embase, Cinehal, there are so many. And then we have other resources like the associated to different groups. Like here we have the Medical Association of Kenya. They have a resource of different categories. So sometimes, depending if you're looking at, let's say, maternal health, then it can be a good resource for you. So apart from the electronic databases, there are other sources, and I think Wambui will discuss more on the Cochrane Library. And we'll end here. Sorry, I've rushed and jumped other sessions, but I'm sure we can make up for this another time.
Yes, asante sana, Barbara. Thank you very much. And thank you everyone for staying regardless of the glitches that we have had. That's really important and very assuring for us. And so our second speaker will be Wambui Njonge, who is a senior librarian and coordinator at Cochrane Kenya. She is an information specialist with experience spanning over 15 years, and she's responsible for information gathering, analysis, dissemination, and maintaining information resources. And as I said, she's currently the coordinator for Cochrane Kenya, which involves activities of the East Africa Hub, administrative duties, as well as managing communications. Wambui, karibu sana.
Thank you, Getrud. Jambo, everybody. I'm assuming I have 5 minutes, correct, Getrud?
Yes.
Okay. I try to condense as much as I could in these slides. Basically, when it comes to systematic literature searching, it's more of a hands-on experience. So slides would not do a lot of justice. So allow me to just speak off the cuff and do the best that I can within the 5 minutes. I know Barbara had alluded when she talked about the practical approaches to EIDM, and one of them is just to search for the best evidence that is out there. So when we talk about systematic literature searching, we're looking at ways of providing a structured and transparent approach to be able to identify and evaluate while also synthesizing the relevant research evidence that is out there. This is because we're looking at minimizing bias, ensuring that we're able to reproduce this research, that the evidence that we get. And we are also able to have a well-formulated decision-making process based on the existing literature searches. I think one of the issues from experience that I've had with clinicians, researchers, basically when it comes to searching for this evidence is because most of us are used to the traditional way of doing searches. I know we've all had an experience here and there doing our thesis, dissertations, and just doing our basic work in regards to doing literature searches. But the traditional approach of doing literature searches is different than the systematic literature searches, based on the fact that when we talk about systematic literature searches, we're looking at we have a plan of how to execute this search. We're not just looking at different articles or information that is out there, but we are structured in the way that, one, we have a research topic that we have in mind. Two, we have our search terms that we want to look into. Three, we have a select database that we need to use to look for this information. And when you're doing a systematic literature searches, the minimum basics that you have to look into is at least 3 databases that should be able to help you to gather the information. 4, we have to run the searches. 5, we have to export and assess the search results. And the last one is, how do we report these searches? So basically, when we're talking about how to select the search terms, I know most of us are, I don't know if we are aware of PICO. So you have to have the patient, intervention, comparison, and the outcome. This will help you within your research question, and also in identifying the synonyms that come into play at this particular moment. We also are looking at how do we build and organize the search terms together in a streamlined and a structured way, together with the keywords. How do we incorporate the Boolean search logic or terms? I know we are well aware of the and or not Boolean search terms. How do we bring this into play as we are building on our search terms and also just refining our searches? And then how do we choose our databases? I know Barbara had alluded to some of the databases that are out there, and today I had thought that we would look at the Cochrane database, given that we represent Cochrane Kenya, and that is one of the 4 core points that we use when we're looking for the systematic reviews. So as you can see from the slide, Cochrane Library is the main output of the Cochrane collaboration. It's owned by Cochrane and published by Wiley. Wiley is one of the publishing companies that focuses on academic publishing, and they provide access to high quality, up-to-date systematic reviews. You can see that it's updated and expanded every 3 months. So it tells you that the information that is there is up-to-date and quality. It has a great impact factor and citation score as well. When for residents of low-income economies listed by the World Bank. So when it comes to access, you have individual access, institutional access, and so forth. So why would you need to use the Cochrane Library? One, as I said, has high quality and up-to-date systematic reviews on healthcare. to help consumers weigh in on the relevant potential benefits and the impact of harm of treatment or research. So as we all know that Cochrane is also very strong on the patient and public network, and they're very key in consumer involvement to ensure that research is relevant, is patient-centered, is impactful for the public. Cochrane itself has quite a number of databases. I will not get into them in specifics. As I said, some of these things are more practically experienced than theoretically. So they're listed. As I was saying, I think after this meeting, I think individually, I would encourage that you visit the Cochrane Library, registers individually. I don't know if your organization has registered under this, but feel free to do that. Also, please reach out through the chat box, even after the meeting, in case you need more information on this. We will be glad and willing to help you out. Lastly, I think, as I said, the challenges I've seen most of the users or the researchers or clinicians experience when they're doing the systematic literature searches is one, time constraint. It's quite involving in terms of time. So patience is a virtue when you're doing this. Also, another thing I've seen is just the knowledge and the skill. Most people are either not willing or maybe they don't have the time to develop the knowledge and the skill. When you do it is when you learn, and the more you do it, you become better at it. And there's also quite a lot of information overload. Remember, you're looking at information from at least 3 databases. So you're really trying to bring everything together. And the last one I think I would point out is just different databases use different thesaurus or syntax. Basically, how they produce the search results is different. So you need to have a better understanding of each database and how they're able to refine their searches and what happens at the back end, given that different databases present differently. So I would end there, but feel free to reach out, and I hope we'll have better and more interaction with your team to at least do a few of these things hands-on. Allow me to also point out one thing, which is very important. As you're doing your searches in the Cochrane Library, there's also what we call plain language summaries. Typically, these are just found in the full text of the search results, and they just are able to just give you an overview in plain language. And not with the scientific or the research jargon. And this can help you even as you meet policymakers, just to bring the conversation down to their level, or even as you're dealing with the consumers or the patients. Thank you so much, and thank you for listening.
Yes, so thank you very, very much, and heartfelt apology from myself, the department, the presenters, the founders of Zoom, etc., for all the technical glitches that we've had today. But really, thank you very much for staying up until this time, regardless being 16 minutes late. I don't see questions in the chat, but I have key takeaways from the presentations today that for us, I think what speaks for me personally, and I believe for many of us, is that the primary research and the research evidence that we produce is really just at the beginning point to get to that desire that we all have, that the research that we do will sometime and someday, and hopefully not too late, change or influence practice so that we can achieve the better population health that we all aspire for. I believe every now and then when one of us has been asked, why are you in research? Why are you a researcher? Somehow, probably in different languages and formats, but you've said that you want to do this because you're enjoying, providing evidence that will be used to improve health and well-being of the people. So knowing that we take this as an initiative, and this was really an interest and conversation starter, so that as a team, as researchers, we really take charge to see how we go through all the flow chart that was shown by Barbara, to make sure that the research evidence that we produce is of good quality and robust, and can be used to go through the steps in the flow chart so that it informs policymakers' decision making and it is taken to scale. One feeling that has been stated by the presenter, which I believe also heard within our rooms and offices at HI many times, even said by our director, that we operate in silos, and that is not good in terms of this evidence coming together to improve population health. And so that is a challenge that we also take. And also evidence on its own is not enough. And sad news is that many times when policymakers sit down, probably evidence is not the first thing they're looking at to get their decision. It's whether they'll still remain relevant in their seats or not. So we take those as challenges, but we, if time allowed, we would talk more about AI, etc., especially in evidence synthesis and literature search. But also speaking to what Augustine Joachim has texted in the chat, that this is a nice presentation and discussion. We might need more time than this. And let me assure you, team, that this has just been the beginning of the conversation with Barbara. And within the department, we're still working on planning, but the preliminary news is that Barbara, probably with a team or solo, will be able to visit our institute in the coming month. We'll provide more information about that, but I hope today's presentation has sort of instilled interest and forms of which we can engage so that we do evidence synthesis, and we would work with policymakers. We empower them in terms of using evidence for decision making, and we contribute to improving health as we all desire. Thank you very much to everyone, but thank you to Dr. Honorati Masanja amidst your very busy time. You've stayed with us. If you can hear us, if you'd like to say a word, please, karibu sana, and then I will be back to close. Dr. Masanja, karibu.
Thank you so much, Getrud, and the department for organizing this this discussion. It's really important and pertinent at this juncture. You know, there's a lot of evidence coming out, but is it relevant really to inform policy? So I really thank the presenters. A few glitches, but I think we managed to get the content, and I'm happy to hear that you're planning to be here in person. I'll make sure I attend while you're here. Asante sana.
Thank you very much, Dr. Masanja. Thank you very much again, Barbara and Wambui. Thank you for taking through the, still holding on regardless of the glitches. And thank you to everyone who stayed. Please stay tuned. We'll communicate about the next steps in the coming few weeks. And thank you, Dr. Grace. I will not invite you again. Sorry, Dada, because of the time, but thank you very much for together organizing this. And with that said, colleagues, have a good rest of your day. Thank you very much.